So welcome to our webinar, FGC in the Clinic, a dialogue between survivors and healthcare professionals. We're going to start in 2 minutes, but in the meantime, if you're joining, feel free to introduce yourself in the chat box by telling us your name, locations, and why you wanted to attend this webinar. Okay, so it's 6:02, so we're going to start the webinar. My name is Sandra, and I'm one of the program's interns with Sahiyo, and I'll be co-moderating today with Zara. Zara, do you want to introduce yourself briefly?
Sure. Hi, I'm Zara. I'm a third-year medical student, and I volunteer with Sahiyo.
And to provide some context about Sahiyo, we're an organization working to empower Asian communities to end female genital cutting and create positive social change through dialogue, education, and collaboration based on community-based involvement. Maria, one of Sahiyo's co-founders, is here today. So do you want to introduce yourself briefly and talk about your work?
Sure. Thank you so much, Sandra. So my name is Maria. I am one of the 5 co-founders of Sahiyo, and thank you all for attending the webinar today. And we're hoping that'll be a really fruitful discussion. And thank you to all the guest speakers in advance for being here and for speaking to us really about the support and resources and what is needed in between healthcare professionals and women who have undergone female genital cutting or mutilation. I'm really looking forward to the conversation and just seeing what comes out of it today. And thank you to Sandra as well for really helping put together this webinar. I'll turn it back to you.
Maria. Thanks, Maria. So today we'll be exploring how female genital cutting, or FGC, is addressed in the clinic, and we'll be joined by 5 panelists who are healthcare professionals, advocates, and survivors. And through their conversation about their experiences with FGC in medical settings, we hope to expand on the vital need for cultural competence surrounding FGC, especially in the healthcare field. So next slide, please. So before we begin, I wanted to provide a roadmap for what we're covering during this webinar. So first, we're going to talk briefly about what FGMC is in the context of global health, and then move into the Voices to End FGMC project, which was a storytelling initiative created by Sahiyo in partnership with Story Center that 3 of our panelists today, Renee, Sarata, and Mariam, have all taken part of. And from there, we're going to jump straight into the panel discussion. And if at any point in the discussion you have any questions, you can submit them in the Q&A box below, and we'll try to answer them during or after the panel discussion. And just as a reminder, during the Q&A portion, you can submit questions anonymously and we can answer them, or I can also promote you to panelists so that you can speak directly to the panelists. And finally, after that, we'll have a slide of resources and contact information that we'll also send out after the presentation. So without further ado, we're going to start by introducing our panelists. Next slide, please.
All right, so our first panelist, Dr. Margaret Dow. Unfortunately, she couldn't be here due to clinical duties, but we'd like to introduce her anyway, and we'll sort of incorporate some of her thoughts later on in the discussion. Dr. Dow is a clerkship director of the obstetrics department at Mayo Clinic. She works with medical students, peers in the community, and education and advocacy for survivors of FGC and in trauma-informed care practices. Our next panelist is Dr. Renee Bergstrom. Renee is a retired patient educator who works towards ending FGC by sharing her survivor story, and she's also an avid weaver. And then Dr. Deborah Ottenheimer is a director of the Women's Holistic Health Initiative at Harlem United Nest Community Health Center, where she is focused on immigrant health, as well as the development and implementation of a multi-specialty medical service for women and girls affected by FGC. In addition to her clinical practice, Dr. Ottenheimer spends a significant portion of her professional time assisting asylum-seeking women who have suffered human rights violations.
And our next panelist is Karen McDonnell. Dr. McDonnell is a public health programs, evaluation and implementation specialist with over 15 years of experience working with community groups, public health agencies, and healthcare systems, both locally and globally, to ensure the health and well-being of women and children. And our fourth panelist is Mariam Sabir. Mariam is a fourth-year medical student at the American University of the Caribbean. She aspires to become a family physician that provides comprehensive care for all her patients, and she's also an avid Sahiyo volunteer. And our last panelist is Sarata Kande. Sarata is a student, entrepreneur, and youth advocate for Inter-African Committee. She is an FGC survivor and loves to share her story, and she also dedicates a lot of her time to both advocacy and her family.
All right, so just so we're all sort of on the same page, we wanted to talk about what FGC is. So FGC, as defined by the World Health Organization, comprises all practices involving the removal of external female genitalia or other injury or modification to the genital organs for non-medical reasons. So on average, girls are subjected to FGC between birth and age 15 is the usual age range. And it's not prescribed by any religion and has no purported health benefits. And it can have long-lasting physical and psychological effects. Next slide.
And one common misconception is that FGC only occurs in sub-Saharan Africa, except according to the UN, female genital cutting is a global issue that affects at least 200 million girls and women in 30 countries, with many more at risk of undergoing the harmful practice every year. It's also important to acknowledge that this figure may be an underestimate of the true number of women and girls who have undergone FGC, as this figure only shows countries mostly within sub-Saharan Africa, and FGC is a very global issue. In fact, a recent report from Equality Now, US End FGMC Network, and the End FGM EU network found that FGMC is found in 92 plus countries around the world. And it's also important to recognize that this practice occurs in the United States as well, affecting approximately 513,000 women and girls, or its consequences in 2012. Again, this number may be a very underrepresented figure, as it's largely based on extrapolated data involving immigration patterns from 30 or so countries that the UN has collected from on FGMC. And this figure also doesn't include those who were born in the US, second generation or subsequent generations born in the US, and it ignores women who have undergone FGC and come from countries other than the 30 listed in the UN.
All right, so we wanted to provide this visual representation of what FGC can look like. So the World Health Organization divides it into 4 types, and it ranges from type 1, which is removal of the clitoral hood with partial or total removal of the external female clitoris. And then the most severe is type 3, which involves apposition of the labia minora or majora, so sew them together and just leave a small hole for menstruation and urination, and it often covers the urethra. And this can or cannot include removal of the clitoris as well. And And this can lead to a lot of, like we mentioned earlier, psychological as well as physical consequences. And it can last a lifetime. Next slide. All right, so before we start this video, this is Renee Bergstrom's videos. And this is her Voices video. She's one of our panelists. And I'd like to encourage everyone to share any reactions or thoughts they might have in the chat box as you watch the video. I'm not sure I can hear it.
No. It's because I was muted, sorry. Let me start that again.
I was born in 1944 to a loving Midwestern American farm family. We were close to the earth and our animals. When I was 3, my mother became concerned that my face turned red when I touched my clitoris. She brought me to a doctor, and the doctor cut me. My mother said, "Don't ever talk about this." I was alone with my questions as a child, teenager, and young adult. I did not discuss nerve damage discomfort, even with my sisters. When I gave birth to my first child, I did not talk about the complications I faced. I wanted a natural labor, but the doctor didn't know what to do. He put me under to perform an extensive episiotomy. I awoke 4 hours after my daughter was born, and it took my body months to heal. I told a couple from my church about what had happened to me as a child. They said, "Don't ever tell that story again." Later, I shared with women at work who said, "Don't repeat that or you'll ruin your career." But is this really my shame? What about other women having their babies with doctors who don't know what to do? I could not stay silent, and I started reaching out to new people. My Somali friend Filsan Ali and I produced a bilingual brochure for infibulated Somali women to give to their doctors to make safe labor and delivery plans. I went public internationally, and my close friends and family supported me. Creating art and connecting with nature has helped me heal. I've learned to spin wool and weave on a loom. I have found peace in flower gardens, weeding, deadheading, and making bouquets. Today I live where eagles soar and deer feed by a river. I hope my story will help people be aware that girls have been cut in cultures throughout the world.
Thank you, Renee, for letting us share your video. It's always really powerful to watch. Our next video is Sarata's Voices to End FGC video. She's another one of our survivors and a panelist.
Growing up, I found out that someone took a precious piece of my womanhood. They say it's a tradition to make me a clean woman, a taboo to talk about. Should I be ashamed to share the untold part that cutting, sewing, or any genital alteration can cause unpleasant sex, vaginal dryness, the inability to orgasm, difficult childbirth, and even death. Does having bad periods to the point where I end up in the emergency room make me a clean woman? When I was younger, I went to a small local neighborhood clinic. Thanks to the Inter-African Committee, where I gained the courage to talk about my story, and my beloved father, who didn't think it was so shameful to try to end a tradition. I had the confidence to let the doctor re-examine me, and I asked, "Is all this pain from the fact that I've been cut?" The doctor couldn't say more than 3 words. Is FGM so shameful that we cannot educate US providers about it? She promised to educate herself. She missed the opportunity to properly examine my mom and aunt, who are also her patient. I didn't want her to miss the chance to provide good care to other cut women. Years later, I saw a more experienced gynecologist who I thought could know more about FGM because he worked at one of the biggest US hospitals. But even after his exams of me, and after he performed surgery to rule out fibroids or endometriosis, he couldn't tell me if my FGM was the reason I had so much period pain. The only answer I got then, and still get from others now, is that a lot of women go through period pain. Maybe once you have a baby, the pain will go away. Now, I also question if another negative consequence of FGM is that after 3 years of marriage, I still have not been able to fulfill my duty as a true woman. In my country, a woman is called a muso, a queen, only if she can create the kingdom. Will my questions ever be answered? Would I ever be a muso?
Thank you to Renee and Sarata, who both created such impactful digital stories. As we saw in the videos, there is a possibility for health complications such as what Renee and Sarata touched upon in their videos, and other health complications include severe pain, excessive bleeding, or long-term vaginal and pelvic infections, and pain during sex. This is not an exhaustive list, but some possible negative consequences, and it's important to remember that every survivor's experience is unique. To speak a bit more about health outcomes, we're honored to have both Renee and Sarata on our panel today. So thank you both for joining. And I'd like to start out our discussion today by asking if you could both talk a bit about your experience with FGC to the extent that you are comfortable doing so. So is there anything that you want to tell the audience that wasn't featured in the video, or anything you'd like to expand on? If Renee, you could start us off.
Okay. The main thing that I wanted to talk about was the lack of partnership by my gynecologist. Not until 2 months after my first baby was born did he actually bring an anatomy book and say, "Renee, you do not look like other women." And he was shocked when I told him how it had happened. But that conversation could have happened during our prenatal visits. And maybe even if he didn't understand that my scar wouldn't stretch, at least during labor, when I did not want to have any anesthesia, when my second stage labor stopped, I was given anesthesia and did not wake up until hours after the baby was born. If we had discussed the different options, my scar could have been opened at that time, and it would have saved me 30 years of an uncomfortable tugging that lasted until my scar separated on its own during menopause. So it's that partnering with your patient when there are difficult situations ahead that I would highly recommend to all of the people who deal with those who have been cut.
Thank you. And Sarata, do you have any thoughts?
Well, my main concern is mainly for patients that do go to the clinic and they're so shameful that they can't even tell the doctor about it. And if the doctor is more experienced and do have the knowledge, I feel that they can have a way where they can communicate to get the patient to open up to them, because it is something that we are taught to never talk about. That go everywhere. Once it's done to you, you are forbidden to even have ever mentioned it to anybody. So we don't see it that when we go to the clinic, the first thing that we should tell the doctor is, hey, I look different from other women. I feel that it's very important for the doctor to know exactly who they're examined, to know the difference between us and other women.
Thank you, Sarata. Now we want to sort of switch gears to the clinical perspective. Our next question is for Dr. McDonnell and Dr. Ottenheimer. What are your initial reactions to what we've heard about Renee and Sarata's care? And in what ways do you think it could have been improved? And we'll start with Dr. Ottenheimer.
I haven't seen those videos before, and they are amazing. And unfortunately, what happened to both Renee and Sarata in different generations in different parts of the world is very common. I think physicians in particular and medical providers in general are taught not to show uncertainty. So even for those providers who didn't know, they didn't say they didn't know. They didn't understand. The partnership with the patient is a critical piece. In my own practice, I see probably about 10 to 15% of my patients have been cut. And because of where I work in New York City, I ask all of my patients if they have ever experienced any kind of gender-based violence, whether it's physical, sexual, or FGC or trafficking. And in that way, I try to normalize the question so that it's not a racially profiling question. Probably most people wouldn't ask Renee about FGC. But I try to ask everyone about gender-based violence in general, and then go on to partner with my patients regardless of what they say and offer them resources.
And Dr. McDonnell.
I want to second everything that Dr. Ottenheimer has said. There, as you just heard from the videos, there's a lot of shame, there's a lot of stigma, there's a lot of silence. And so if we as providers don't know how to ask and don't ask, then you really miss an opportunity for, as Renee said, a partnership to have responsive care. You may be the lifeline that connects somebody to needed services. But if you as a healthcare provider don't know how to ask, don't know how to show vulnerability, you can't expect that your partner, your patient, is going to be the one to start that conversation. And that's why it's so important what Maria and Sahiyo has been doing is to create these videos, these storytelling, so that you know, as a healthcare provider, you don't have to wait for somebody to walk into your office to know what women and girls have experienced. You can hear somebody's story and sort of vicariously learn from that. And I think that's really key. And also having resources available about what women want, how they want to be asked. I think that is very empowering for both the clinician and for the woman. So I think it's really up to all of us to be vulnerable and to ask those questions, but ask it in a way that is non-stigmatizing and really creates a partnership. I mean, you can hear it in people's stories, it actually is quite simple, but very hard to do. But if we go that extra step, it's amazing the partnership that we can be creating and the bridges that we can be building between women who have experienced FGM and the healthcare providers that are supposed to be providing the needed and necessary care.
I would add two other things. One is in the physical medical profession, as opposed to the psychological space, we have an unfortunate habit of calling students in to come and see things that are unusual or interesting. And this is not a space where that is appropriate. FGC is something that women are taught to be ashamed of, that you're never supposed to mention it. And bringing in the third and fourth year medical students and the intern to come and look at a woman in an incredibly vulnerable situation is inappropriate. And I had another point, but now I don't remember what it is. I know. I think the other piece that's important is when you're in the treatment space as opposed to the advocacy space, is that when I'm in my exam room with my patient, I never assume that I know how she might or might not feel about what happened to her. I have patients who are not bothered by their cutting or are proud of their cutting. That's not where I live in my activist hat, but that is where I live when I'm wearing my physician hat. And I think it's important to separate those roles if you carry both of those roles in your life.
Thank you for that, Dr. Ottenheimer. Just reflecting off of that, something that Dr. Dow, who isn't here today, wanted to say along the same lines were that she would begin the conversation from a place of neutrality and beginning from conversation in an adversarial perspective. If you do that, then you would have ended it before you start. So I definitely agree with that. To follow up on that question, so Dr. Ottenheimer, when you encounter a survivor FGC, what is your approach? And how would you respond to some common questions you might receive from your patients?
I think there are two ways that happens. When I do my history and my history before I do my physical exam, I always talk to my patients with their clothes on, sitting on a chair, not with me standing over them and not sitting on an exam table. And it is in that context that I ask a lot of sensitive questions about sexual function, about sexual experiences, about experiences of physical or sexual trauma. And I do ask about FGC in that time. So sometimes that's a time of revelation and we can discuss it close on. Sometimes it isn't. And then the discussion happens during the exam. And I try to be neutral. You know, I ask people where all the scars on their body come from. And sometimes they come from a surgery and sometimes they come from a beating. Sometimes they come from a bike accident or a straddle injury. Sometimes they come from a birth injury. Sometimes they come from FGC. But I always ask if I see something that is not typical. I try to avoid the word normal. I also try to avoid the word, usually when I show women pictures of unaltered anatomy, I refer to it as uncut, not as normal. again, because my cultural vision of normal is not necessarily that person's vision of normal, but it is unaltered. I always offer to show them pictures similar to what they look like, but I also offer to show them with a mirror their own anatomy.
One question that was brought up in the chat box was from Vicha Adri. It's common to do episiotomy during labor in Indonesia, and they were wondering if this was a common normal labor procedure.
So I trained in OBGYN in the 90s, and that was a time of great change in the United States. When I was in medical school, everyone did an episiotomy on everybody. By the time I finished my residency 8 years later, nobody was doing episiotomies unless you needed to facilitate the birth of the child. So that has evolved, and it's evolved largely because there's a lot of evidence that episiotomy causes sexual dysfunction later. Depending on how you do it, it can cause quite a lot of pain as well. So I think now, at least in the United States, the general practices try to avoid it as much as possible.
Thank you, Dr. Ottenheimer. You talked a lot about important points that I hope to integrate into my future clinical practice. Our next question is for Mariam. And Mariam actually also did a Voices to End FGMC video that I'm going to link in the chat box for anyone that wants to view. But our question is, as a medical student, can you tell us a bit about how FGC is taught in medical schools in your experience? And then how do you think it can be improved?
Of course. Hi, everyone. It's great to be here. I was never taught about FGC in medical school. My first time learning about FGC was in a healthcare ethics course that I took in undergrad. And that was the last time I was ever taught about FGC in an academic setting. Everything that I've learned about FGC has been through Sahiyo, and really nobody in med school has ever even brought it up to me. But what we do focus on is we talk a little bit about the external genitalia, but never about the issue of FGC in med school. As far as, I think the second part of the question was, what can we do to improve the education, right? So that's a tough question. I feel like the medical school journey is so long, it's 4 years long. So the question, and then there's residency training after that. So the question arises, where do we want to incorporate teaching about FGC? So everybody has a different opinion. In my opinion, I feel like we need to start at the basics. So we spend very little time learning about the external female genitalia. So definitely spending more time learning, as Dr. Ottenheimer said, the typical anatomy, so that we know what the variances are when we look at it. Starting that early, and then in the 3rd and 4th year of medical school during rotations, when we do our physical exams, it's such a habit to just go straight for the pap smear or straight for the pelvic exam. But, really taking the time to examine and inspect what we're looking at. And once again, that's how we're going to learn what's typical and what's not. So emphasizing that as well. And then in residency, more of the cultural competency, like trauma-informed care, how to deal with patients, and how to bring it up in conversation. That kind of training can really be hammered in during residency. But FGC as an issue can be talked about all throughout, so that when we do see a patient, at least it's on our radar, and at least we're aware that it even exists, because most healthcare professionals don't know that it exists in the United States. So.
Thank you,
Dr. McDonnell.
I just wanted to ask any of the other panelists if they had anything to add about what Mariam said in terms of education about FGC. Sarata.
Yeah, really what Maria covered is my most concern, because you're coming across with a doctor that don't even know what FGC is or never heard about it is kind of a shame too, because you're going to see a doctor that you feel that should know your body very well. So I think that it's very, very important that in the US government should apply some type of way where FGM is like a chapter in the book, or there's some type of resource how to know how to talk to us. Or again, there's a lot of volunteers like myself that will go to the hospital and let a doctor and a medical student examine me, because I feel that I'm giving the learning experience for that student. So I think that that's possible to make that happen, to do like a chapter definitely in the medical book, because it's something that the whole world should know, especially doctors.
That's very brave of you, Sarata.
Yeah.
Dr. Ottenheimer.
So, one, those chapters are being written. It's slow. Medicine is a big beast to change, but it is happening. I've had the privilege to teach about FGC in a number of medical schools here in New York. I think there's a growing recognition that medicine needs to incorporate trauma-informed care and also ethics and human rights. And in that context, FGC seems to get wrapped in, although what year, it really depends on the program, to be honest with you. But also in terms of physician training and nurse practitioner training and physician assistant training, another really important thing to remember is that this is something that happens to children. This is something that I see mostly adults, but I also see pediatrics. But something that we don't get taught in medicine is to look at the minor girl, infant girl's external genitalia. It looks really, really, really different than a grown-up woman or a post-pubertal woman. And the only way we're gonna find kids who were cut as little ones here in the United States, as Renee was, is for us to begin to feel comfortable looking at little girls in a normalizing way during their routine annual exam. I'm the mother of 2 boys. My pediatrician always did a genital exam. My friends with girls, never happens. And so I think that's another really critical piece to our education that is missing.
I'd like to share that I spoke to the second-year medical students in Dr. Dow's class and gave a history of my interactions with physicians throughout my lifetime, which they seem to respond to very well.
Mm-hmm. And if I may add, the reason why it's so important to me that it is in the book for the medical students to learn is that a lot of places in the world is not so diverse. Like when I first moved here in Cleveland, it wasn't so many of us, I would say, so that's why a lot of the doctors, mainly, they didn't know about it. But as time changed and now we have more Africans or more culturally people that have undergo FGM, the doctors are kind of starting to know about it. But that's why I'm kind of insisting that it should be in the medical book somewhere, because every doctor should know that this exists.
And Dr. Ottenheimer, what you said about asking gender-based violence questions or history of abuse to the patients, as a medical student, I was only taught to ask that in my psychiatry rotation and in no other rotation. That definitely needs to be normalized as well.
Thank you all for your valuable insight. I think medical school education is an important system to preventing gender-based violence in the future, but I'm interested in Dr. McDonnell, your work in public health and knowing what type of systems are currently in place to take care of survivors of gender-based violence and how you think we can improve those systems of care.
What time is it? How much time do we have? One of the things that we haven't actually talked about yet are the numbers. So, do you guys know 200 million women and girls today in the world have experienced FGC, and that's what we know about, and that's from surveys that we've taken. You know, a few years ago, we actually thought the number was, 150 million, because we hadn't asked women and girls in Indonesia. And when we included those numbers, it rose to 200 million. So asking these questions, we know that about 3 million girls were going to have FGMC this year. So when Dr. Ottenheimer talked about not using the word normal, because in some places it is normal to have been cut. So, we're taking this from a very US-centric point of view. And so when we talk about systems of care, it's really important that, especially in the US, we have so many people coming from all different parts of the world. People might not see this as something that's not normal. And so, but we know that there are health implications. And so we need to be providing systems of care that integrate how people talk about their health and well-being. We actually need systems of care that, what is that? So we need to create supportive environments. We have to educate. So being knowledgeable, we can't be ignorant. So it's really, I think it's fantastic that we have so many attendees to this webinar right now. These are people eager to know more about FGMC, that they're aware that it exists. So we have to be knowledgeable. We have to share that knowledge that we have. We have to create effective communication, create a language on how to talk about it. Talk about genitalia. It's not your vajayjay. It's, your vagina. Let's talk in real terms. And as healthcare providers, do your homework before you see your patients. Have resources available. You don't want to be caught off guard. If somebody comes and does talk about it, you want to be ready with resources that are available for them. So again, it's so important. We've been talking about training in medical school, PA, NP, RN, PhD, MPH, DRPH. Being prepared, being knowledgeable, knowing about resources. And I think we'll get to that in a little bit in the webinar about some existing resources.
To follow that up, we had a question from Amanda Lopez. Do you have any recommendations on how to normalize and ask patients about this, especially as a medical student? So you talked about resources, and are there any recommendations that you have? Oh, to Dr. McDonnell.
Oh, so we do have, as you'll see on a toolkit that we developed, there are ways, and it's not just one way is the best way. You really have to become knowledgeable about different ways, because it all depends also on your interaction and your comfort. And I know Dr. Ottenheimer, you talked about some of the ways that you normalize the conversation, because it's not just FGMC that we're talking about here. It's talking about child abuse. It's talking about gender-based violence. So it's not just, I know we're focused here on FGMC, but it's a form of child abuse. It's a form of gender-based violence. And so it's really important when we look at the statistics on gender-based violence worldwide, we're talking over 10%, it depends on your population, but anywhere from 10 to 60% of your clinic population will have experienced gender-based violence. So it's almost unusual to not at times run into somebody who's experienced some form of violence. So it should be normal in your practice on inquiring about that experience. And so I don't know, Dr. Ottenheimer and Mariam, you guys have just, you're doing this on a daily, and Mariam, in your training, what were some of the things that you've been taught to do?
Taught to do in terms of, sorry.
Asking in your interactions.
About FGC.
About gender-based violence, FGC.
Yeah, like I had mentioned earlier, it's just during my psychiatry rotation that I was really taught or told to ask about these questions, but really nowhere else, and sometimes in family practice as well. I remember this one time I was in clinic, and there was a couple where I did suspect FGC, and the patient was pregnant as well. And I brought it up with as a student, we're very limited as to what we can ask or what we can do. So I brought it up with the resident, and she said that she was not She was like, oh, she brushed it off. She's like, oh yeah, I don't really know much about that. Okay. Well, like the big thing is if, even if you don't know about it or you're not comfortable in it, in talking to the patient about it or educating them, at least be aware of the resources and provide that, because that's a missed opportunity to provide care. So, yeah.
I think something that's starting to change in medical education, probably family practice and advanced practice nursing and mid-levels have it on us compared to the MD education, but is to examine your own prejudices and your own assumptions and your own discomforts. There's a presumption that, medical professionals should feel comfortable talking about everything. And in principle, you should, but you don't come to it that way. And it's really important to do that work in school and with yourself so that you are able to have those conversations looking someone in the face, not blushing, not being uncomfortable, because if you're uncomfortable, your patient will take the cues from you and they will be uncomfortable. And I think that is slowly percolating through the medical professional education. But we don't, the other thing is, I talk to my colleagues and I get the eye roll because, we don't have time. But you have to have time. You have to make the time. A lot of people will say no. Have you ever experienced this, or this? No. Okay, done. But if they say yes, then you need to tell the front desk that you're going to be busy and you'll be late. And that's just how it is. Whether it's rape, whether it's domestic violence, whether it's FGC, you have to ask the questions.
Thank you, Dr. Ottenheimer. To sort of build off of the experience Mariam shared in the clinic, Amanda Lopez has another question. And she asks, when encountering FGC survivors in the clinic, what resources would you recommend we can offer to patients? And is there a typical management plan that you have that you sort of go through? Dr. Ottenheimer, shaking your head.
One of the big issues with elimination, I'm going to be quiet, it is that it's not a one size fits all, and the resources that your patients need also is not a one size fits all, and it really depends on where you live. So I am lucky enough to live in New York City, and we have a lot of resources to offer, but I have a feeling that in other parts of the country, we don't have so many resources. So it depends on how technologically enabled that person is too. If they can access things online, if they know how to read, if they know how to read in English, if they know how to speak any number of other languages. So I think that's part of the conversation. How can do you have issues around this, and how can I help you? And once the patient identifies their needs, then you can try to find resources for her.
Jean?
Yeah.
You are coming on upstairs. So if you want to shut off, and it's making everything echo.
Renee, I think we can actually
Yeah, I got
it. Just to let you know.
Yeah, so following up that question, we have a question from Deborah Colhane, and she asks, is there a thought to use Title IX advocacy as a way to get medical schools to include more curricula for FGMC and GBV, or gender-based violence? That can go to Dr. Ottenheimer, Dr. McDonnell, or Mariam as well, if you want to answer.
Could you repeat the question one more time?
Yeah, the question is there a thought to use Title IX advocacy as a way to get medical schools to include more curricula regarding gender-based violence and FGMC?
I don't think there has been that thought, but I think it's a good one. It's one that I know I can say for college campuses are dealing with. The current administration has sort of constrained some of that a little bit. So maybe come January, we'll see some differences in how we can utilize different things. I will say one of the things that we are looking forward to in terms of policies is HR 6100, which had, it's the Stop FGM Act. And that just passed unanimously through the House of Representatives. It is now in the Senate. And I strongly encourage everyone here to contact their Senate representatives to pass HR 6100. And I say this in this realm right now because part of this bill has resources attached to it for just what we're talking about, to create systems of care, to create epidemiological surveys so we know number of women, where they live, where are they from, what are their health complications. It is the one bill that I think can really make a difference besides ones that exist right now, that is specific to FGMC, that actually does in the bill talk about health and healthcare and systems of care. So that's my advocacy hat on right now. So everyone that is here, I'll put it in the chat. It's called HR 6100, Stop FGM Act. Please contact, because there's a lot going on right now in the Senate. And if we can get this one in, like I said, it passed the House unanimously. That never happens. So, let's consider it a win. So thank you.
Thank you, Dr. McDonnell. Please definitely share that link in the chat for us. And then I also just wanted to add that we are talking a lot about education and how FGC is taught at the medical student level, the resident level, at the physician level, and there are a lot of grassroots things going on. Sahiyo is working a lot with medical school education, and there's lots of residents out there doing their own projects and trying to implement that program by program. So our next question is for Renee, Sarata, and Mariam. Reflecting on our whole conversation so far, what do you think are the most important lessons or messages that you would want to tell doctors and other healthcare professionals to be aware of when working with survivors? And we can start with Renee. I think you're muted, Renee.
We are survivors, but we're much more than that label. We are resilient people who have very full lives, and so it is not appropriate to just see us by that label.
Thank you. And Sarata?
I'm sorry, can you repeat the question one more time?
Sure. So based on our conversation we've had so far, what do you think are the most important lessons or messages that you want to tell doctors and other healthcare providers to be aware of when working with FGC survivors?
I think the most important thing for us is trying to have that sense of care, like take the time to really show us that you care about this situation. Take the time to really comfort us in some type of way, because that was something I really needed when I was being seen at the hospital. And it really broke my heart that the doctor didn't know anything and I had to be the one to really educate him on this. So I would say the best way is to find a way to communicate with us, that partnership of what Renee was saying.
Thank you. And Mariam?
I think just going off of what Sarata said, as healthcare professionals, I feel like patients come to us with questions and we need to have the answers. And so we're so used to kind of knowing or being under the impression that we know everything or have to have answers for everything. This is the one case where I feel like you can bring up that conversation, even if you don't know everything about it, you can offer them resources. So sometimes, some survivors may want to talk about it, some may not want to talk about it. Some want to be recognized and, be seen, and some may not want to talk about it at all. So just meeting them where they're at, and also don't I think we've talked about this a lot, but no judgment, because there are a lot of survivors who take pride in this tradition as well. So just keeping that in mind is so important. So just coming from a place of no judgment, and yeah, I think so. Just overall, just be aware that it exists, look out for it. And even if you're not completely comfortable in providing the proper care, start the conversation and give them the resources. Like, look up what's available in your state, what resources you can offer them, have that handy in case you ever need it.
Yes, and may I add that listening is your most important communication tool.
That's true. A lot to learn as well.
Mm-hmm.
Survivor.
And I will add one more thing is to know when to ask the question. You may not want to ask us when we have like a family member, when it's better if you ask us like when we're alone, because you don't know what that person, we probably don't want that person to know, or how we're relationship with that person. But most of the time as a survivor, I think it's easier for me to talk to somebody just by themselves than to talk in a group today. But thank God that now I have that ability to be strong enough to talk about it in front of so many people. So I think just knowing when to talk about it is also very important.
Also keeping in mind that every community that practices it or have a different term that they might use. So you can always ask the patient, what term are you comfortable to like be addressed by? Some say female genital cutting, mutilation. At Sahiyo, we prefer not to use mutilation, just because it's more harsh. So we say cutting, but then I belong to the Bora community, we call it katna. So sometimes just using those terms that are specific to the patient can help them feel so much more comfortable.
Thank you, everyone.
And just add one last thing, I'm sorry. I think a good question for us would be, do you know about FGM or do you know about FGC? Things like that to start the communication, give us that comfort or that sense of open of a conversation. Then we feel like we can open up to you and talk about our experience.
Great point.
Thank you, Sarata. That was yes, I agree. So that just about wraps up our panel discussion, and we're going to be moving into our Q&A portion. So if you have any questions, you can submit them in the Q&A box that people have been using already, and we'll try to answer them right now. So if you want to submit any questions anonymously, we can answer them, or I can also promote you to be a panelist so that you can speak directly to the panelists with your camera on. So just starting with our first question is, what challenges exist for LGBTQ and transmasculine assigned female at birth men who have a history of FGC, and what resources are out there that support people with this intersection of identity and experience? Feel free, any of the panelists, if you have expertise on this or want to answer, go right ahead.
I have to say I've never seen it, and that doesn't mean it doesn't exist. I have a few patients most of my patients are West African who identify as gay, and I see many trans men and trans female patients, but I've never seen the intersection of all of these issues together in that way, to be honest.
There's a lot of work that needs to be done with FGM, so we have miles and miles to go.
So much.
Let's incorporate this as well in the future.
Thank you. We have a question from Hunter, who is a former programs intern, actually, at Sahiyo. And let me try to... Hunter, are you in the attendee box? All right, when I can find her, we can answer a question live. But the next question is, from an anonymous attendee. It says, in what areas of medicine do physicians still practice FGMC? So maybe we can talk about the medicalization of FGM and that trend.
I'm hoping that there's no medical specialization that practices FGM. It had, we always hear that, it wasn't taken out of sort of a code until the 70s, but I'm hoping that there is no medical specialization that actually practices it, especially as we're talking about in the US here. But I'll leave that in. Dr. Ottenheimer, do you know of any in the US?
I mean, the definition is for non-medical reasons.
Right.
So in the United States, it is not a sanctioned practice. Although it's really important, before the 70s, and Renee is an example, it was an accepted practice for what was seen as hypermasturbation or hypersexuality or lesbianism among young little girls. But in other countries, especially in Egypt, it is a very highly medicalized practice. For a little while, there was some thought that could mitigate it, because maybe if a medical professional did it, it would be less harmful or less severe or more sterile. And and Indonesia too, more by nurses than doctors, I think, in Indonesia. But that's turned out not to be the case. And one of the problems with that is that it also lends legitimacy. If the medical practitioners adopt it as an acceptable medical practice, then you're giving the practice legitimacy, which is a problem.
Thank you. The next question is from Hunter, and she asks, what kind of work is being done to educate doctors and create resources for medical schools?
I feel like we already touched on that one a lot, so maybe we could answer.
Karen's going to share the toolkit
Yes.
she created.
All right. We have a question from an anonymous attendee, and it says, are there patients who are not aware of what was done to them because it was done at such a young age? Is education a large part of this?
I guess I can, so part of what we've done is we interviewed over 26 survivors of FGM, and we did hear from a couple who had been cut as infants, and so had no recollection of it happening to them, and didn't know that it had happened to them until we call them turning points, until they had a turning point where I think for one, it was, being pregnant and having a gynecological exam and saying, what happened to you? And the person saying, like, what do you mean, what happened to me? Right? So yes, and so I think somebody mentioned in the chat, in Indonesia, they had been we're seeing it in the news being offered as part of the birthing plan, is having cutting done. And so by having it done at a younger and younger age, what is the thinking? Is the thinking that it happened so young that the person doesn't even know that it's happening to them until they have a turning point and or have physical and mental health implications later on, in different points of their life.
And Sarata, do you want to add to that?
I will say in some culture, mainly it's done when at a very young age, because they don't give the girl to say, yes, I want it done, or no, I don't want it done. You don't have a say so when you're an infant.
Thank you. Our next question is to Renee from Dina Bader. She says, since you voiced your story, have you heard of testimonies of other white American women who have undergone FGC?
Yes, I have. And when one of them told her story, some of the people who came from the same community also shared that it had happened to them. And even one young person had recently had her daughters cut, not realizing that it was not the thing to do. So yes, it does still happen here in the United States.
Thank you. And to respond to that, to the healthcare providers, speaking to asking questions and being non-stigmatizing and being vulnerable, would you say that this response should be true worldwide and not just in the States? Or would you do the same in the US or Uganda, et cetera?
I think when you're practicing in other countries, you have to be mindful of what's appropriate in those cultures. I probably talk to my American patients in ways that are different than when I'm in, say, Haiti, where I've spent a lot of time. You have to be mindful and culturally appropriate. So I think the lessons are still there to listen, to ask questions, but you have to use language in a way that is going to not be offensive.
Mm-hmm.
And a question to Renee and Sarata is, have you ever experienced a provider who has asked about FGM without you bringing it up first? And what did that provider do well?
No.
No, not at all.
Have you had an experience of a primary care physician who has been good about that in general?
Yes, yes. I've had primary care physicians who were very compassionate and had wonderful discussions, but only after I brought up the topic, not that they brought it up themselves.
I won't say for me, but for my mom, when she was giving birth to my little sister, I had a little relationship with the doctor where I did make sure that he knew about my mom's condition. So we communicated a lot about FGM, and he did his resources before delivering my baby sister, and he was very passionate about it. So I will say for my mom, yeah, but not as for me. Every doctor that I've seen so far, I've been the one to mainly educate them about my experience.
Thank you. And just as a reminder, if any of the participants want to be promoted to a panelist and ask their question face-to-face, you can just privately message me and I can do that. So the next question is, do you believe, or to any of the panelists, do you believe in the near future that there will be doctors dedicated to FGC patients? And do you feel that it would be better to have specific doctors for those patients?
I mean, if I had my choice, it wouldn't. When I did focus groups with my patients here in New York, they very specifically didn't want to be singled out. They didn't want to have a special clinic with a special day that was just for them. It reminded me a lot of HIV in the 90s, when we thought that specialized care that was separated would be better, but in fact, it's quite stigmatizing. So I'd rather see all of us educated and all of us able to handle issues of gender-based violence in general. We need specialized surgeons, but maybe not the initial piece.
Right.
Well, as you showed before, the slide with the health ramifications, there are physical health ramifications, mental health, And so it's important that every healthcare provider is knowledgeable on gender-based violence and its short-term and long-term effects in every realm of health, not just physical health.
Thank you. And the next question comes from Richa Adri, and she says, is there nurse practitioner training for FGC in the US, or does that happen only for OBGYNs?
I mean, I think the goal for all of us is to educate, and when I do my education, all providers are welcome, but I don't think that there's a specific education for nurse practitioners or certified nurse midwives. Nor do I necessarily think there needs to be. I think we all need to know about it.
And I can say that our toolkit was actually tested on physician assistants as well. So we had a class of, I think 60 physician assistants that actually tested the toolkit out.
All right, so we have another question that I think is for the clinicians, and also Mariam, if you'd be willing to answer. But what role can a primary care physician play in this? Often gynecological questions are referred to an OB-GYN automatically, and what about other specialists? So how can other people help out?
Okay, well, go ahead.
No.
I'm applying to family medicine this year, so I do hope to play an important role as a future family physician when it comes to my patients. I think, like I had mentioned earlier, a lot of patients sometimes want to be seen or may not want to be seen, and that Dr. McDonnell said this too. They have a variety of problems. It may not always be OB-GYN related. It could be urology related. It could be, mental health problems that we could help them with. Just having those resources at hand would be really helpful, and also having that open discussion with them will also help them feel better or feel like they have someone they can come to. And that's a big thing about being a PCP, is just being an advocate for your patient. You might not have all the answers, but as long as they know that they have someone that they can come and talk to, or somebody who's advocating for them is big, as a PCP especially.
Thank you. Our next question, related to the more medically related, is how does cutting affect birthing and delivery, and would a labiaplasty qualify as FGC practice in the US?
Those are two really different questions. The birth, it really depends. It depends on the scarring. Scarring is really idiosyncratic. It depends on how much tissue was removed. It depends on whether it was type 2 or type 3 or type 1. And remember that as someone who's birthed my own children, giving birth is a really emotional experience. So even if you had a very small amount of tissue removed, or technically a small procedure in terms of FGM, you may be incredibly emotionally traumatized. And so the act of birth and being vulnerable in that space may be just as affecting on the birth process. So I think it depends, and you just have to plan for it, and that's where the communication comes from. The question about labiaplasty is a really hard one. Currently, the laws in this country, and Karen should correct me if I'm wrong, but apply only to minors. So in some states, labiaplasty is actually the fastest growing plastic surgery performed on teenagers. And for people who are doing that, they may well be violating state and federal law, but it hasn't yet been tested in the courts. For grown-ups, it is not considered under the law to be FGC, although there are folks who wonder about the element of coercion and conforming to a particular trope that is involved, and so coercion may be involved, and perhaps we should consider it. In other countries, in the UK, it is, and Canada also, adult labiaplasty is considered to be against the law, but it is also not prosecuted.
Thank you, Dr. Ottenheimer, for having that information on hand too. So our next question is for Renee and Sarata. So if you guys are comfortable sharing, of course, but the question is, did you confront your parents as an adult survivor, and how did their relationship, how was it affected? If you're comfortable answering.
I basically protected my mother most of her life by not sharing the story. But my mother lived to be 101, and I confronted her when she was 95, and we had a very good heart-to-heart talk. And so by the time she died, we were both at peace with our relationship. But there is, I think I am not alone in, when this happens as a child, there is that sense of betrayal by the person who was supposed to protect you. And you lose a sense of childhood and sort of grow up too fast. So I think we had a role reversal in that I became my mother's protector, even though I was only 3 years old. And that's what being silenced does to a child.
Thank you so much for sharing that, Renee. Sarata, would you like to share anything?
Well, as for me, I really didn't hold my parents accountable too much because from a very young age, my dad did educate me a little bit about FGM, that it may happen to me, and he was doing his best to, you know, prevent it from happening to me. But unfortunately, he couldn't fulfill that. But what I did was, and still am doing, is protecting my younger sisters. So this is mainly the reason why we moved here in the United States. So my parents did their best to at least give us kind of an escape way. Fortunately, it happened to me, but that's why I'm using it the best of my ability to make it stop. But I don't really blame my parents, although I feel that they could have done better. But it was kind of hard for them to prevent it from happening to me. And again, protecting your mom and stuff, because if my parents really made sure that it didn't happen to me, people would come after them or treat them a certain way for not letting it happen to me. My mom will be called names, or my dad will be called name. And my tradition is is different. In my country, 98% of women have undergo FGM. So it's like something that must be done. So my parents didn't have too much of a choice.
Thank you both for sharing. We also have another question for both of you, and it's Could you share as to how your experience with FGC outside of the medical field has impacted or continues to impact your life to the extent that you're comfortable sharing?
Having my story come out in 2016 was about the most freeing thing that ever happened in my life. And so keeping a secret can have emotional impact, have an emotional impact. And so when it's no longer a secret, there's a great freedom.
And I will say, when you do tell your story, Renee, it feels good. Most definitely. It feels phenomenal because you feel even powerful, because we are taught that it's a taboo to ever open your mouth to say that this been done to you. So to me, outside of the medical field, sometimes yes, as a young person, and especially with my story that I mentioned, I've been married and I still haven't been able to conceive. So things like that could make me uncomfortable a little bit, or when I'm out or having girls talk with friends. But thank God I do have very good friends that listen to me, and they know now. But when you have that girl talk and sexual talk, sometimes I do feel a little uncomfortable and a little shameful. But as I grow up, I think that's being changed. And again, when I speak more about my story, that definitely helped.
Thank you so much for sharing, Sarata and Renee. So I'll have Maria, if you could share your screen again. I'm glad we had so much time for question and answer. I thought that was really valuable.
Great questions.
Yeah.
One second, I'm just getting it.
Sounds good.
While Maria is getting the screen, I would like to say something to somebody. I think it's Isabel. And Maria answered you and said that FGM is banned in 39 countries. Now, I would like you guys to keep in mind that, again, as this is a taboo for us to talk about it. So even though like in my country, it's been banned, but you would never see a girl that will go to the police or somebody for help because their parents or a family member have taken them to get FGM done, because a family can disown you for ever bringing them to the police or having some type of justice done to them because they had you cut.
Also vacation cutting. I won't get into details because we're running out of time, but vacation cutting happens a lot.
Exactly.
Absolutely. So this is our resources slide that we just wanted to share with everyone so you can do further reading and have access to some of the things that we talked about and we'll still talk about in the last few minutes, and we'll hopefully get that out to everyone. And I also wanted to share Dr. McDonnell's resource. She developed it as a community-centered project to raise awareness about FGC. It's going to be linked in the presentation, but Dr. McDonnell, would you be able to talk about the GW toolkit a little bit?
Sure. Can I share my screen?
Sure.
Oh, there you go. All right, let's see. Okay, so can you guys see my screen?
Yep.
So myself and our team, it was an amazing experience, and there are some members of the team who are here in attendance today, so I just want to acknowledge their presence that are here. And we're actually continuing to build this out as well. This is our toolkit. It's aptly named fgmtoolkit.gw.edu. And this was developed over about a 2-year time period. And it is developed with the voices and the experiences of women and healthcare providers. And you can see here we have menus, so you can see who we are. And this is the team that developed the toolkit. if you have experienced FGM or you want to know more about it, you can visit this part of the website and you can see, you know, what is FGM? You can see, again, pictures. How does it affect physical health? Somebody mentioned mental health. And so here is a resource, and you will see that all of this is curated, meaning that there are references that are in the peer-reviewed literature that we have read, and we feel confident in linking to them. It is multimedia, so there are case studies, there are people's own stories, we have videos, there are resources. We have a list of resources, so healthcare providers and clinics, and faith communities, local government agencies, and here's a support group, and I want to point one out here, is a Global Woman Peace Foundation. They actually do have a support group just for women who have experienced FGM. I think it's the only one in the country. And now that we are in COVID, it is telehealth in a way, so that people around the country, I guess around the world, can participate in it. So I highly suggest linking to that. And for those of us here today who are healthcare providers, again, we have a quiz on our website, the competency areas that are being served by the toolkit materials, a training course that we and others have developed, and then a workbook. And then also, you know, again, going through what is FGM, why screen for it? So if you go here, how to screen for it, what can I do? What questions can I ask? Questions I should be prepared for when I screen. Looking at women's own words in terms of the do's and don'ts. And also, again, resources. Somebody also mentioned, how do I discuss FGMC with my patients? Here are words that you can use, do's and don'ts. And all of these were developed through our in-depth interviews with healthcare providers and with women. So everything that is on this website was developed with them in mind and actually with their feedback. About pregnancy, what if my patient is pregnant? Here are some things to think that you need to keep in mind, as well as video. And, you know, additional information. So clinic guidelines, we keep this up to date. Fact sheets for yourself and for your patients. Courses and learning tools, organizations that are working on FGM, and videos, including some of the work that we have done with Sahiyo. We are currently also developing the community toolkit. And again, if you have other questions, always feel free to reach out to us. And if we don't know the answer, we will find it for you. So again, this is fgmtoolkit.gwu.edu. It is a living toolkit. It will be changing because we hope that different laws get passed and different clinical guidelines get updated, because we know that some of them haven't been updated in a while. So keep visiting, and anything that you want to add to the toolkit or reference, please let us know. We're happy to share.
Thank you, Dr. McDonnell, for sharing and for creating such a comprehensive and great toolkit. It really taught me so much when I was first getting into FGC advocacy, so thank you for creating that. We're almost out of time now, so I just wanted to thank all the guest speakers for coming. I think we had such a great and productive conversation, and I hope that everyone who attended took something valuable away from the conversation. So thank you again for coming to our webinar. I've listed all our contacts here if you want to reach out with any questions. If you have any lingering questions from the Q&A that you want answered, you can email us at info@sahiyo.com, and we will try to gather with the speakers and figure out the best way to answer these questions, whether it be by email or another form of media. So you can follow us on Facebook, Instagram, Twitter, and keep updated on what we're doing next. Thank you so much for coming, and that's it for today.
And one last thing, please call and have HR 600 stop FGM. Please call. Thank you.
Thank you, Sarata, for reminding us. All right. Bye.